time, our first speaker is Professor Choudhury Meshkat Ahmed. He will be talking on myocardial viability assessment and the clinical implications. So let's hear from Professor Ahmed.
Assalamu alaikum and very good afternoon. Viability is what we refer as life. Anything that is alive is viable. In normal myocardium, it is viable. If this myocardium have inducible ischemia, it is also viable. But more important thing when we need to know about whether a tissue is viable or not in a situation when there is myocardial infarction, whether the infarction has got a through and through thickness scar or it has got partial thickness are important. If it is partial thickness, then the portion of alive myocardium is important. And of same note, hibernating myocardium is another important, very important aspect of viability that we need to know whether the patient has got hibernating myocardium or not. And of course, stunning and myopathic myocardium are also viable. Main confusion that we face in clinical practice is hibernating myocardium, stunning myocardium, and the myopathic myocardium. Because these are the myocardium and the partial thickness infarction. These are the myocardium, they are akinetic, functionless. And when something is not moving, we don't think that they are alive. Anything that does not move is not alive. Anything that moves is live. But it is not true for viability of myocardium. There are some myocardium which do not have function, but still they are alive. And of all these four items, that is partial thickness infarction, hibernating, stunning, and myopathic, we have to pick partial thickness infarction, and we have to pick hibernating myocardium for revascularization. And again, when the partial thickness infarction has got ischemia, then it is important to know whether it is viable or not. So only two aspects of viability. One is the hibernating myocardium, and another is partial thickness myocardial infarction, which has got potentiality of reversible ischemia. So in the context of coronary artery disease, this is a common scenario, partial and the full thickness scar. And more important is the hibernating myocardium. Generally, we get the ischemic cardiomyopathy and the heart failure in elderly people. So myocardial viability is a continuum. It is not just yes myocardium and no myocardium. It is not a dichotomy. So in a particular group of myocardium, how much cell are alive, it is difficult to say. And this is the historical paper, the iconic patient, Rahimtullah in 1982, when first showed that after revascularization in patient with myocardial infarction and having CABG, there was marked improvement in myocardial contraction because there were viable myocardium. From here mooted the concept of viable myocardium. Sorry. So actually, when a patient's myocardium is hibernating, it has got flow, but not enough flow reserve. So that it hibernates, but it does not go to the function. Once it goes for some function, then ischemia might have occurred. So we need to separate these three terms. That is hibernating myocardium and stunning myocardium and viable myocardium. As I have said, anything alive is viable. The hibernating myocardium, please remember, the alive myocardium, number one. Number two, reduced resting function. It may be severely hypokinetic and akinetic. And the most important point in this context is recovery after revascularization. And on the other hand, stunning myocardium is alive. It is hypokinetic or akinetic, but it recovers spontaneously. It does not need revascularization. Revascularization has got nothing to do with that. So any trade that happens between revascularization and viability is in the currency of hibernation. So we'll have what we want to understand is hibernating myocardium. And in among many cardiologists, it is the concept of viability is concept of hibernation. What they mean by viability, they mean hibernation, which is true as a matter of fact. Actually, our target is the hibernating myocardium, because as a cardiologist, we want to revascularize those portions which will give benefit to the patient. So there are proposed mechanisms, chronic reduction, but the more attractive hypothesis is repetitive stunning. And here we can see the mortality benefit with hibernating myocardium and other subset of coronary artery disease. And when a patient with hibernating myocardium do have surgery, they get the maximum benefit. So in summary, viable myocardium or akinetic myocardium is part of ischemic syndrome, and the hibernating myocardium is confused with stunning. So what is the goal of viability? To identify patient who will be benefited from revascularization, surely. Prediction, actually, revascularization is going to give him how much benefit. The extent of benefit that the patient is going to get from the revascularization, the amount of viable myocardium which is inducible is actually the factor that will determine how much benefit will get the patient from revascularization. And typically a patient, elderly patient with chronic heart failure, with no scar, and presenting with shortness of breath are the people who are the candidate for this sort of viability test. And actually, we really need to know whether those patients will get benefit from revascularization or they are the candidate for LVAD or other things. So what are the indicators of viability? Angina is a good indicator of viability. Single vessel disease, myocardial infarction, patient having angina, you need not to know about whether the patient has got viable myocardium or not. The second most important thing is lack of Q wave. At the times we get myocardial infarction, but ECG shows no Q wave. And you're sure, more or less, the patient is having some viable myocardium. And when the patient has hypokinesia, some contractility, some systolic motion, then it is again viable. So these three simple things can make you a judgment that you're dealing with viable myocardium. You really need not to do other investigation in those patients. There are areas of investigation I have said about the ECG, the abdominal stress echo. We have SPECT and the PET, and the MRI, the final frontier. So here we can see what is the specificity of lack of Q wave. You can see it is as good as any other investigation, even SPECT. Even better than the SPECT itself. And thinning of the myocardium in resting myocardial infarction is another indicator of viability or not. Myocardial thickness less than 6 millimeter, almost you are not going to get any viable myocardium in there. And it has been confirmed by the SPECT test that when a patient do have a myocardial thickness of less than 6 millimeter, the chances of viability is much less. Of course, through MRI and through PET, some portion of the patient with thin myocardium do have viability, but again, out of those patients, only 20% will get benefit from revascularization. So these are the sensitivity and specificity aspect. There we have the nuclear colleague and the abdominal stress and MRI. I do not want to make any contest among them. I'm not going to go into details, but as an echocardiographer, I want to show you the benefit of stress echo for viability. Remember, if the patient has got left ventricular systolic volume of more than 130, the patient is not going to get the benefit of revascularization. Biphasic response is by far the most specific and most useful parameter for viability. So, biphasic response in our laboratory. So in dobutamine response, we can get three sort of response. If there is sustained improvement, this can be stunning myocardium, this can be myopathic myocardium, this can be T-third action, and by any means, those people will not get any benefit. But on dobutamine stress, if there is biphasic response, those are the patient will get benefit. And if the patient deteriorates from the resting wall thickness, then again, that is also a sign of viability. Here in this picture, you can see the biphasic response and the worsening response are the people who have got some viability in the myocardium, and those myocardium are going to get the recovery. If there is sustained response improvement, despite the patient was having akinetic myocardium, this patient is not going to get any benefit. So putting wall thickness and the biphasic response give you a good sensitivity and specificity, and you may not need the PET and MRI in those cases. The dobutamine stress echo also can show you the amount of scar. I think I should stop here. Thank you very much for your attention.